Hi everyone, I'm going to talk about how to navigate through different hybrid applicator for gynecological brachytherapy. As we all know that use of hybrid applicator is going up because of better therapeutic ratio, and there are a spectrum of hybrid applicator available. I'll discuss some of these applicator which are available with Bravos and Variant technology to discuss the uses of this applicator, the pros and cons of the approach, and some practical tips. So we know that the dosimetry has changed significantly for cervical cancer. If you look at ABS 2012 guideline, it said D90 to HRCT between 80 to 90 gray. But now Embrace 2, which recently reported their studies, aim for D90 of 90 gray with a lower limit of 85 gray. It also had other factors or dosimetric factors available, like if you contour GTV, a D98 of GTV of 98 and above, with keeping 0.8 dose to 65 and above. Similarly, the organ at risk doses have also changed significantly, like from ABS 2012 guideline of keeping rectum to less than 75, sigmoid to less than 75, bladder to less than 90 for 2 cc dose. Now in Embrace 2, based on some of the available outcome data, the aim was to keep 2 cc less than 65 gray for rectum, 2 cc less than 70 gray for sigmoid, and 2 cc less than 80 gray for bladder. Besides that, for vaginal toxicity, the rectovaginal point was defined to keep below 65 gray, and ICRU bladder point was defined to keep it below 75 gray. So you can see over a period of time, the doses to target have gone up and the doses to organ risk have gone down to improve therapeutic ratio. But to keep these doses, it is important that the advanced applicator are used. And based on this Embrace 2 study, which was recently presented at Astro, I'll show you the data, more and more people are going to use hybrid applicator to improve therapeutic ratio. Like the Embrace 2 data was presented at Astro by Dr. Potter. It is a single arm phase 2 prospective study using advanced IMRT, IGRT for external beam with SIB boost, and also adaptive brachytherapy using MR-based brachytherapy with decreased dose to rectum, bladder, bowel, and vagina, which I showed previously. They recruited about 1,450 patients from 49 centers worldwide. And if you look at it, when they reported the results, there was significant improvement in local control with a 3-year local control of 93%, the nodal control of 95%, and distant control beyond periodic nodal control of 88%. Similarly, the overall survival at 3 and 5 years was 87 and 82%. But more important, look at grade 3 morbidity. The grade 3 to 5 urinary, GI, and vaginal morbidity was 8.9%. In contrast to Embrace 1, where these grade 3 morbidities were significantly higher, reaching between 25 to 30%. So the conclusion from this study was substantial improvement in therapeutic window in comparison to Embrace 1, with risk reduction of disease progression by 17%, risk reduction of death by 2%, but most importantly, risk reduction of grade 3 to 5 morbidity by 45%. And basically, this established MR-based brachytherapy as a standard of care. And important to understand that 74% of the cases in Embrace 2 used hybrid applicator to improve this therapeutic ratio, to achieve high dose to the target and reduce dose to the organ risk. So in this talk, I will talk about some of the hybrid applicator and give some practical guidance. So these are the hybrid applicator I'm going to cover. The first one is an Aarhus applicator. It has got a tandem and a ring, but there is no ring channel. It has straight and oblique needles to cover both medial and lateral parametrial disease. The second applicator is the tandem ovoid, which has both straight and oblique needles with guide tube to help placement of the needles. So the third one is the interstitial cylinder. Interstitial cylinder has got multi-channel in the cylinder, but the important thing is the needle from the tip from the interstitial cylinder can go into the cervix, and it can be combined with Kelowna template. And the fourth one is multi-channel cylinder with Kelowna template. The difference between multi-channel and interstitial cylinder is in interstitial cylinder, the needle can go through the tip into the cervix, while on multi-channel, they end at the tip. So when you're using one of these two applicators, you have to be careful in what you want to cover and how do you want to use it. So hybrid applicator for brachytherapy, like let's talk about the Aarhus applicator. So Aarhus applicator, as we all know that when that main advantage, one of the main advantages of hybrid applicator, you don't need to go to perineal tissue. You can get your desired results through transvaginal route, which makes it easier on the patient. You can achieve the goal with less needle and less penetration. And the small ring of the Aarhus helps you with insertion. Like the cases I have done, the smaller ring of the Aarhus helps you in patients with smaller anatomy. It has got both straight and oblique needles, so you can pick up the needle position based on the pre-brachytherapy MRI. But one important aspect I want to highlight, it doesn't have a ring channel. So if you're using this applicator, you have to use needle on both sides to supplement the dose distribution like ring also. The one way to get around with this, the standard ring and tandem, which is of the same size as Aarhus applicator, can be used if you're not planning to use the needle. But if you're planning to use the Aarhus applicator, you have to always use the needle. It has, as I said, it has got both straight and oblique needle. The outer one is the straight, the inner one is the oblique. You can see how the needle, the hole placement works out to be. Most of the time you place the needle laterally to replicate the distribution of the ring. And then you can see this is the straight needle and this is the oblique needle, which helps you cover medial parametrium and lateral parametrium. Now this is the hybrid applicator for people who are used to tandem and ovoid. It does a similar job as Aarhus applicator, just the fact that some people are more used to tandem and ovoid, so they prefer that. Again, it is versatile and flexible. It has also got both straight and oblique needles. It is MR compatible. There is thin tandem. Like if you feel this tandem is thick, you can use the needle tandem also in some people where it's harder to place the thick tandem. As I said, it's got parallel and straight needle. It has got rectal retractor, and the basically the guide tube helps you better control the needle placement because you can control the depth from the outside and insert based on desired depth, and you can mark the patient here to push the desired depth. So it's a similar concept as ring applicator with needle, but for people who are used to the ovoid, this may be the preferred way to do it. It's not, it is individual preference. I favor ring applicator, so I tend to favor Aarhus, but some people may like tandem and ovoid, so they may favor this applicator. Now this is the third one. Like you can see, this is the interstitial cylinder, and you can see the needles go out. There are oblique. Basically, this is how the oblique needle comes out from the interstitial cylinder, and this is multi-channel. You can see there is no needle coming out of it. So both these applicator can be combined with the tandem. So you can do tandem with interstitial cylinder like this, where the needles come out obliquely, so you can help cover the cervix and parametrium. And the advantage is because you're using the cylinder, you can extend the isodose line inferiorly. So it helps you cover the disease in the vagina, which sometimes could be a factor for ring and the ovoid, because the coverage of the ring or ovoid is for the few centimeters in the vagina. If it is more than that, this helps you out. Both this applicator can be combined with Kelowna template. So if you want to go more lateral or add more needles, you can use template. But when you use the template, then you're going to perineum. So this part of the applicator is through the vagina, but this part of the applicator goes to perineum, like any other template-based brachytherapy. So it's a versatile applicator. You can do tandem and interstitial cylinder alone. You can do tandem and multi-channel, or you combine tandem and multi-channel with Kelowna template to add to your flexibility. So the general guidance is a single intrauterine tandem provides adequate dose coverage for approximately 2 centimeter tissue on either side of the uterine canal. So it can change based on anatomy, but about 4 centimeter of symmetric disease. If you add one row of straight needle, you can further extend the coverage by additional 1 centimeter. So you can go up to 3 centimeter from the midline based on the number of needles, weighting and dwell position using the needles, and the symmetry or the configuration of the tumor. On top of that, if you incorporate additional oblique needle, you can go add another 10 millimeter. So you can go up to 4 centimeter from the midline based on, again, location of the tumor, number of needle, and dwell position of the weighting. These are not fixed rule, but this will give you the guidance. So if it is up to 4 centimeter, you can cover with tandem. More than 4 centimeter, up to 4 to 6, you can make cover with single a straight row needle. But if you have to go beyond that, you have to do oblique needle. The insertion depth of the needle is usually between 2 to 4 centimeters above the surface of the ring of the ovoid, based on the length of the cervical canal and vertical dimension, which you can see on the imaging. So normally I go up to 3 centimeters, but sometimes it could be more or less. But when I'm pushing oblique needle, I'm a bit more careful because oblique needle, when they go beyond cervix, can be close to parametrial vessel. The straight needle usually tend to be in the cervix or the uterus to have more safety, but oblique needle could be closer to parametrial vessel. So I'm very close to it because of potential risk of vascular injury. I tend to sometimes under push it and adjust on the CT scan. So my workflow is, if I do the placement under ultrasound guidance, I'm at the time of the CT scan, I may adjust the oblique needle a bit more if I'm not sure about it at the time of the placement. So this is example of Aarhus vaginal template with straight needle. You can see the disease is around 4.5 centimeters or so. And so what we did was we put the tandem and we put the Aarhus template, the smaller Aarhus template. We use these row of the needle, the lateral ones, and only the straight ones. So the inner one are straight, the outer one are straight, the inner one are oblique. You can see the two needles placed on either side, and which helps you cover the disease. You can see the depth of insertion is maybe around 2.5 centimeters going up to the cervix. So this is uterus, this is cervix, so depth of insertion is into the cervix. You can see straight needle, even if you push more, it still remains within the cervix or the uterus. Now you can see by these are the clinical goal, you are able to achieve your so-called embrace dosimetric guideline with a D90 of 85 to 90 and above, D98 of 95 and above, and D2C bladder, rectum, and sigmoid of 65 for the rectum, 70 for the sigmoid, and 80 for the bladder. So this slide shows you the steps for the Aarhus applicator placement. So you can see that initially you pick up the Aarhus template, you preload the needle. In this case, I'm preloaded 4 needles, 2 on either side based on the pre-brachytherapy MRI. I make sure the needle tip is right just up to the surface of the Aarhus template so that when I'm inserting it, it doesn't hurt the patient's vagina. And as I said, we prefer blunt needle to decrease the risk of trauma and bleeding. When I'm inserting the applicator, the ring applicator, I follow the same principle. I turn the ring 180 degrees. So you can see, not once it is inside the patient, this part would be more anterior, but I start this as posterior. By doing this, what happens, I can negotiate through the narrow part of the introitus easily. So I insert, basically rotate it by 180 degree. Once I insert, go to the introitus, I turn it around like this and click it to the tandem. This way it's easier to insert. I check everything on the ultrasound. Once I'm happy with the placement, I push the entire ring and the tandem all the way up to the cervical os, check with the speculum. As you can see, I will check with the speculum. And then I push the needles in. When I'm pushing the needles in, I look on the ultrasound, usually between 2 to 4 centimeters, depending on the patient's anatomy. You can see I'm pushing all the 4 needles in and then connecting them to the needle collector. I keep the mandarin on till the CT scan is done. Some people take it out if they're comfortable with the ultrasound view. I keep the mandarin on. So once my workflow is, once this is done, we do the CT scan, look at the needle placement, look at the tandem placement. If we're happy with it, we take out the mandarin and then send for the MRI for the planning. If I'm not happy with it, it is easy for me to push the applicate needle in with the mandarin on, because otherwise it becomes a bit harder, and it's very easy to push the needle with the mandarin on. And that completes the procedure. Similar kind of case, but instead of Aarhus, you're using tandem and ovoid with the needle. So you can see similar kind of case, about between 4 to 5 centimeter width. You are putting 3 needles on either side, but with the tandem and ovoid, you can only push on one side, do on the other side, depending on your clinical scenario. But the goal is still the same. You are pushing the needles on either side based on your need, and then doing the planning. So whether you use Aarhus applicator or tandem mode with a straight needle, the goal is similar. The only thing is with Aarhus, you have to put needle on both sides. With tandem and ovoid, you could only push on one side if you don't need on the other side. This is the oblique needle placement. You can see the disease is closer to 6 centimeter. It's going more posterior lateral, involving almost like a uterosacral ligament. So because it is involving almost uterosacral ligament, what is happening is you have to put an oblique needle also. So you can see we are using the similar hole, but both straight and oblique needle. You see, we put 2 straight needle and 3 needle on the left side, but there is an oblique needle to cover this disease. I want to show you on the sagittal, you see the oblique needle on the image D. If you push too hard, it goes outside. That's why I said be cautious on the oblique needle, but you can achieve the goals, as you can see from your dosimetry clinical goals. So an example of how why on the lateral side or posterior lateral side, the oblique needle of the Aarhus needle helps out. This is another example of oblique needle with the tandem ovoid with the same goal. You can see the disease is more width. Because of larger width, you need to use both straight and oblique needles, so you are achieving the same goal. So whether you use ring applicator or tandem ovoid applicator, the principle of using the straight needle and the oblique needle is same. And whenever you use the oblique needle, then you push the oblique needle on one side or both sides depending on the need. But the goal is very, very similar, as you can see. This is an example of disease in the cervix, but you are seeing there is upper vagina involvement about 3 centimeters, so which is slightly more than what you could be covering with your ring or the ovoids. You can see this is the antevaginal involvement. You can see it's a bit bulky disease. So to cover this disease, you need to have an applicator which can extend the isodose line inferiorly. So in this case, it is tandem with interstitial cylinder. So you can see this is the interstitial cylinder with the tandem. It has got oblique needles as part of the interstitial cylinder, so that helps you cover the cervix and medial parametrium. And since it is going, you can extend the isodose inferiorly, it helps you cover the vaginal disease. You can see the isodose line here is covering upper 3 centimeters of the vaginal disease, which is what we want to cover. So it is covering cervix, it is covering medial parametrium, and it is also covering your vaginal disease. And you can see from the needle placement, the reason why some of the needles were placed anteriorly was to cover this disease, so that you can have better control of the isodose line covering this disease. And you can see you can achieve the clinical goal. So just to show you an example of why you need sometimes interstitial cylinder or to extend the isodose line inferiorly, but you still need needle in the cervix because the tandem by itself will not cover the cervix. So using interstitial cylinder helps you out. Similar kind of case as the previous case, but if your site doesn't have interstitial cylinder, then you have to use some Kelowna template to cover the cervix. You can see that you place a tandem in the uterus. This is the multi-channel cylinder, but there is no interstitial needle coming out of it. So to cover the cervix, you have to put needle through the template. So this is an example of tandem with multi-channel cylinder. Since you do not have needles getting into the cervix, you have to use the Kelowna template, the first row of the Kelowna template to cover the cervix. So you can see you put 2 needles on each side to cover the cervix, and your multi-channel helps you cover the vagina. So similar goal as the previous case, except the fact that since it did not have interstitial cylinder, so to cover the cervix, if you are using multi-channel cylinder with tandem, you have to push the needle to the Kelowna template, like this case. Another example where the disease is much more extensive. So it's not only it's covering going to the vagina, it's also going too far lateral. You can see like big width of the disease, like 6 to 7 centimeter width. So if you are going to cover with the template, you have to an interstitial cylinder. The interstitial cylinder will only go to a certain extent. So you have to put some needle through the template. So you have a needle through the interstitial cylinder. These are interstitial cylinder needles, but the lateral ones are through the template. So you can see you are extending your isodose line more than what an interstitial cylinder can do. So this is combining your tandem with interstitial cylinder with Kelowna template to supplement the needle. And the goal to supplement the needle is to go lateral. So the template helps you go lateral, and it also helps you go inferior. So some people prefer that whenever they have extensive disease because they have better control. They do single insertion and 4 or 5 treatments. And you can see how the needle through the template is helping you extend laterally, and the cylinder is helping you extend inferiorly. So an example of how you can mix match the applicator. You can mix match tandem with interstitial cylinder with Kelowna template, tandem with multi-channel with Kelowna template depending on the need, just to show you the flexibility. One other flexibility part I want to explain. So this is the tandem and ovoid, and the tandem and ovoid has with interstitial with a needle, but you can see sometimes you only need needle on one side, not on the other side. So this applicator allows you to combine a normal ovoid like this side to an interstitial ovoid like this side. So you can see the normal ovoid, the ovoid channel is in the center, but the interstitial ovoid, the ovoid channel is medial. So if you don't need the needle on one side, I would encourage you to use the normal ovoid because the loading channel is in the center. It gives you more flexibility rather than being very medial. And on the side which you are using the needle, you can have this ovoid with medial channel, and that can help you out. Like for example, I can show you this example here. You can see it's the tandem and the channel is in the center, the channel is in the medial, and you're combined with straight or oblique needle. So it gives you the flexibility of combining different ovoids, an ovoid with needle to without needle depending on the need. And by doing this, you are able to maximize your coverage with minimal intervention. And by using this, you don't need to use needle on the side where you don't need it. And by using normal ovoid, you have better dose distribution than a medial ovoid. So just to give you some perspective of how to combine and mix match the two. So if I have to summarize the configuration summary, the Aarhus applicator is a vaginal template. It has got straight and oblique needle, MR safe, small ring, but no ring channel. So you have to always use the needle when you're using Aarhus applicator. It is interchangeable with normal ring in tandem. So if you do first fraction normal ring in tandem, you can use that for simulation planning to figure out what needle to use and what needle not to use. So for the next subsequent fraction, you can use that fraction to simulate the planning. That helps you out because we do it all the time. Sometimes after first fraction, we realize we need hybrid. The tandem and ovoid is customizable. You can mix match ovoids with simple ovoid with needle ovoid. You can have straight and oblique needle on one side. It can help you cover median lateral perimeter disease. It has got a guide tube, so you have a control on the, you can see the depth of insertion of the needle. And also it has got a needle channel. So if you have a stenosed os or internal os, then you can use that also. The interstitial cylinder is something which you can combine with tandem, which you can combine with Kelowna template depending on the need. And same thing with the multi-channel cylinder, you can combine with Kelowna template depending on the need. So by mixing match, you can use one or both or any one of them depending on your comfort level. I usually prefer Aarhus because I'm used to ring applicator, but some people prefer tandem ovoid, so they may use the other one. I only use interstitial cylinder with template in patients with mid or lower vaginal involvement, or if I need to do a bit more extensive implant, which is infrequent, but it is still needed. So for me, Aarhus applicator with interstitial cylinder does the job for all kind of scenario, but some people may do otherwise. Just to be aware, anytime you do a hybrid applicator, there is a risk of bleeding. It could be 5 to 20%. Most of the time, it is controlled with packing. In some cases, the bleeding is persistent, so you need to may consider help with the G1 oncologist for suture placement or surgical intervention. It is also possible to cause injury to OAR. So organ puncture can typically manage conservatively. You retract the needle and don't load the needle. And if you are close to the bowel loop or something, you can consider a course of antibiotic. So in some cases, intracavity brachytherapy alone cannot achieve acceptable dose coverage or OAR constraint, more so with the tighter dose constraint which Embrace2 established leads to better therapeutic ratio. The hybrid applicator allows you to maintain those therapeutic ratio by increasing dose to the target and facilitating lower dose to the OARs. There are multiple applicators which are designed to facilitate hybrid brachytherapy. They offer you flexibility to conform dose to the target, and the brachytherapists who do cervical cancer need to be trained on the practical aspect of this use of this hybrid brachytherapy because compared to template-based brachytherapy, they're less invasive and can achieve the goal with lesser intervention. Thank you, and if you have any question, feel free to email me on my Gmail email, socialbureau@gmail.com. Thank you for listening to the presentation. I hope it was practical and useful. We have also created a white paper. The link to this is in the video. You can freely access this through this website. It will give you some guidance and some of the things which we discussed about. Hopefully, this will help you with the practical application of the hybrid applicator in your practice. Feel free to reach out. Thank you for listening, and thank you all.